early as 2 days after birth, the patient was admitted to the hospital due to abdominal distension. She had this condition as early as 5 hours of age, accompanied with vomiting. Immediately, X-ray was requested at a regional clinic and showed distended loops of bowel. Upon her arrival to the nursery, she was grunting and breathing hardly and rapidly at 66 breaths per minute, which is high, with subcostal retractions and increased bowel sounds. Other findings include hyperglycemia, hypermagnesemia, high white blood cell count, and low hemoglobin.
The next record of hospital admission was when she was 6 months old. Chief complaint here was 8 days of diarrhea and vomiting. Patient was febrile and moderately dehydrated. Weight dropped to 5th percentile from 25 to 50 percentile at birth. Length from 50 to 75 percentile at birth to 10th percentile. And head circumference from 10 to 25 percentile at birth to 5th percentile. There was fluctuation of blood pressure from 70 over 50 to 100 over 80. Both measurements are high for a 6-month-old. Other findings include high bicarbonate, low chloride, and low sodium levels. Management done was via intravenous fluid intended to correct the biochemical abnormalities. The patient was then discharged. The patient was readmitted 5 more times over a period of 2 years, often during hot, humid weather with episodes of diarrhea and vomiting with same biochemical results. On her 7th admission at 4 years and 3 months, findings show elevated potassium fractional excretion at 67% and low sodium.
Ano po ba ulit problema sa bata?
Ba't ganun? Ubo pa din. Tapos meron siyang severe gastroenteritis. May upper respiratory tract infection. Tapos yung lagna, 38.7 degrees Celsius. Ba't hindi gumagaling do?
Tingnan pa natin dyan.
On the next hospital admission when she was 8 years old, she was suffering from severe gastroenteritis and upper respiratory tract infection. Her height and weight were now below the 3rd percentile. She had finger and toe clubbing and bilateral crepitations heard upon auscultation. Patient was febrile at 38.7 degrees Celsius. Pertinent findings include low blood pressure, low oxygen saturation, alkalotic blood pH, low partial pressure of oxygen, high respiratory rate, low chloride, high bicarbonate, high phosphorus, low potassium, low sodium, high creatinine, high capillary refill time at 4 seconds, and low urine calcium and chloride excretion. Sweat chloride is at very high level of 120 milliequivalents per liter, where the normal is 60 or less. Bilateral streaky infiltrates were seen on chest radiography. Sputum culture grew Haemophilus influenza and Staphylococcus aureus. Blood and urine cultures had no bacterial growth. Fluid therapy led to gradual biochemical correction over 3 days. The patient was discharged.
So what is your working diagnosis?
I think our working diagnosis would be cystic fibrosis.
Cystic fibrosis. So would anyone care to discuss the pathophysiology of cystic fibrosis?
So, night tayo, magandang hapon po. Lumabas na po yung resulta ng exam po at lumabas po na yung anak niya po ay may cystic fibrosis po.
Cystic fibrosis is a genetic disorder that affects mostly the lungs but also the pancreas, liver, kidneys, and intestine. Cystic fibrosis is caused by a mutation in the gene cystic fibrosis transmembrane conductance regulator. This gene is responsible for the expression of the CFTR protein, which is a channel protein that controls the flow of water and chloride ions in and out of the cells inside the mentioned affected organs. In a normal individual, the intestinal epithelium expresses the CFTR protein to secrete chloride ions into the intestinal lumen. However, in cystic fibrosis, there is a defect in the CFTR protein which causes the decrease in chloride ion secretion into the intestinal lumen, which causes the more negative intestinal epithelium intracellular space and attracts the sodium ion inside the intracellular space. Thus, there will be a decreased sodium secretion into the intestinal lumen. This decrease in sodium secretion causes a decrease in H2O osmosis to the lumen, which causes a hardened intestinal contents, and this buildup of intestinal contents decreases the contact of iron into the intestinal epithelium, which causes the decreased absorption of iron, leading to the decrease in synthesis of hemoglobin, which is detected in the lab result. Buildup of intestinal contents caused to detect the distended loops of bowel in X-ray, which also cause the abdominal distension. These distended loops of bowel will cause the myogenic depolarization of smooth muscles of the intestine, which will cause the increase in peristalsis, causing the increased bowel sounds detected. As for the respiratory component, in the airways, there will be a decreased chloride secretion, causing a more negative respiratory epithelium intracellular space, causing the attraction of sodium inside of the cells and decreasing the sodium secretion into the airway lumen. This decreased sodium secretion into the lumen decreases also the water osmosis to the lumen, causing a mucus thickening in the airways. This thickening causes an increase in the airway resistance, causing a decreased alveolar air filling, which will lead to the increased negative pleural pressure, causing a decreased expansion of lungs and will be seen as a subcostal retraction. Also, the decreased alveolar air filling will cause an increase in the carbon dioxide and decrease in oxygen inside the alveolus. This will cause an increase in diffusion of carbon dioxide into the blood and will stimulate the chemoreceptors, causing the stimulation of the medullary centers to increase the respiratory rate. Also, this mucus thickening can cause a decrease in mucociliary clearance, causing the entrapment of bacteria and its proliferation, leading to an upper respiratory tract infection. This can explain the increased white blood cell count of the patient. Since the patient is in a respiratory distress, there will be an increase in the secretion of the catecholamines as stimulated by the sympathetic nervous system. This distress will also increase the CRH secretion, increasing the ACTH secretion, causing an increased cortisol secretion, having a more permissive effect to the catecholamines, causing a decrease in insulin release and decrease in glucose uptake. This will lead to the hyperglycemia detected in the lab results. A decrease in H2O diffusion into the intestinal lumen will cause a mucus thickening inside the intestine. This will cause entrapment and proliferation of bacteria inside the intestine, causing the secretion of emetic toxins by these bacteria. These emetic toxins can be absorbed and gain entry to the area postrema, stimulating reversal peristalsis through the vagal efferent, causing a vomiting of hydrochloric acid, causing a decrease in hydrochloric acid absorption. This will lead to the non-reversal of the alkaline tide, causing the increased bicarbonate serum levels and the decreased chloride serum levels. Also, the secretion of toxins to the intestinal epithelial cells will cause a decrease in electrolyte absorption, causing the uncontrolled water osmosis to the lumen, causing the chief complaint of diarrhea. The proliferation of bacteria in the respiratory tract and the intestine will cause an immune response to increase the cytokine production of white blood cells. These cytokines include the interleukin-1, which will be converted into prostaglandin E2, which will reach the organum vasculosum lamina terminalis, stimulating the posterior hypothalamic nucleus, causing the increased temperature or the febrile symptom of the child. Combining the effects of diarrhea and vomiting led to the moderately dehydrated infant. The decreased electrolyte absorption led to the decrease in sodium serum levels, leading to the decreased osmosis of fluid to the blood compartment, decreasing the blood volume, decreasing the mean systemic feeding pressure, leading to the decreased venous return, causing the decreased preload, decreased myocardial stretch, causing the decrease in the number of actin-myosin bridging, decreasing the inotropy, leading to the decreased stroke volume, causing the decreased cardiac output and decreased blood pressure. The decreased blood pressure will cause a decreased stretching of baroreceptors, causing a decrease in firing of baroreceptors, stimulating the vasomotor center to increase the sympathetic nervous system stimulation. This will cause a general vasoconstriction, increasing the total peripheral resistance, increasing the blood pressure. Also, the general vasoconstriction includes the afferent arteriole of the kidney, causing the activation of the renin-angiotensin-aldosterone system, causing an increased sodium reabsorption in the renal tubule, which can also increase the blood pressure. The activation of RAAS will stimulate the excretion of potassium in the renal tubules. This will cause the elevated potassium fractional excretion detected and the decrease in the potassium serum levels. The drastic changes in the regulation of the blood pressure causes the fluctuation of blood pressure detected. As a reaction to the proliferation of bacteria in the alimentary tract, the inflammation of epithelial lining of intestine resulted to the severe gastroenteritis. As a result of the infection, the immune response will release chemotactic factors which will attract the neutrophils to the site of infection. These neutrophils undergoes respiratory burst and is responsible for the sputum production, which can also be seen as the bilateral streaky infiltrates in the chest radiograph. The effect of angiotensin II in the efferent arteriole and the efferent arteriole will decrease the GFR, which will lead to the decreased creatinine clearance and an increased creatinine serum level and an increased BUN serum levels. Also, in cystic fibrosis, there is a decreased chloride secretion to the pancreatic acinar duct, causing the decreased exchange of bicarbonates with chloride, causing the decrease in the bicarbonate in the pancreatic acinar duct. This will cause the increased pH of chyme in the small intestine, causing inactive pancreatic enzymes, decreasing the digestion of nutrients, and leading to the decreased absorption of nutrients. With this, combined with the increased proteolysis and gluconeogenesis as a reaction to the catecholamines, there will be a decreased growth of the child, as shown in the third percentile height and weight result of the child. In cystic fibrosis, as opposed to the intestine and in the airways, there is a decreased chloride reabsorption in sweat gland ducts. This caused a decrease in the chloride serum levels, and also there is a more positive intracellular space of epithelial cells of sweat ducts, causing the repel of the sodium into the duct. This led to the decreased sodium serum levels, causing a decrease in the osmosis of fluid to the blood compartment, decreasing the blood volume, decreasing the mean systemic filling pressure, leading to the decrease in the venous return, decreasing the preload, and decreasing the myocardial stretch. This led to the decreased number of actin-myosin bridging, decreasing of the inotropy, and decreasing of the stroke volume, leading to the decreased cardiac output, which decreased the blood pressure. With this decrease in blood pressure, this now will lead to the decreased stretching of baroreceptors, decreased firing of baroreceptor, stimulation of vasomotor center, leading to the increased sympathetic nervous system stimulation. The increased stimulation of the sympathetic nervous system will lead to the increased heart rate, combined with the increased leakiness of sodium channels in SA node cells due to the increased T set by the infections. Also, general vasoconstriction will lead also to the vasoconstriction of the afferent arteriole in the kidney, causing the activation of the RAAS. Angiotensin II and aldosterone then increases the reabsorption of the sodium in the renal tubule. This will now lead into the increase in the blood volume, causing the increase in blood pressure. However, this increase in blood volume is overpowered by the decreased reabsorption of sodium in the sweat gland ducts, maintaining the low blood pressure of the patient. Also, the increased reabsorption of sodium in the renal tubules led to the chloride movement paracellularly to the interstitium. This caused a more positive tubular lumen, increasing the calcium and magnesium paracellular transport by repelling them from the lumen. This then led to the decreased urinary excretion of calcium and magnesium. Also, the increased reabsorption of sodium in the renal tubules led to the increased reabsorption of bicarbonates via the NBC1 transporter. This resulted to the ABG elevated bicarbonate and increased blood pH. Also, due to the increased reabsorption of sodium in the renal tubule, there is an increased secretion of hydrogen ions via the NH3 antiporter. This led to the enhanced increased blood pH. Also, the increased reabsorption of sodium in the renal tubule caused an increased reabsorption of phosphorus via the sodium phosphate symporter, which led to the increased phosphorus serum levels. The activation of angiotensin II caused the activation of aldosterone, causing the increased secretion of potassium via the ROMK transporter in the renal tubules. This showed a decreased level of potassium in the serum levels. Since there is an increased airway resistance, there will be a decreased oxygen diffusion to the blood, resulting to the decreased partial pressure of oxygen and low oxygen saturation. There is also a decreased carbon dioxide diffusion into the alveolus from the blood, which will lead to the increase in the partial pressure of carbon dioxide, stimulating the peripheral chemoreceptors and stimulating the increased respiratory rate of the patient. Also, the increased airway resistance will lead to a high capillary refill time.
During her fourth admission at age 9, the chief complaint was breathing difficulty associated with cough, productive of greenish sputum. The sustained neutrophil-mediated inflammation that will favor proteases and inhibit antiproteases will result to damage nasal epithelium. Thus, there will be bilateral nasal polyps. There will be an inflammation of epithelial lining of intestine. So at 8 years old, there is severe gastroenteritis. There will be an immune response. The chemotactic factors will attract neutrophils. The neutrophils will undergo respiratory burst, which will lead to cough productive of greenish sputum. In cystic fibrosis, there is a defect in the normal airways, which results to decreased chloride secretion. Because of the decreased chloride secretion, there will be more negative respiratory epithelium intracellular space, which will result to decreased secretion to airway lumen. Then there will be decreased water osmosis to lumen and mucus thickening. There will be decreased mucus ciliary clearance that will lead to bacteria entrapment. In another pathway that leads to cough productive of greenish sputum, because of the spread of infection, there will be a less compliant upper lobe of lungs, which will result to decreased oxygen in the upper lobe of lungs, and the decrease in oxygen will allow the thriving of Pseudomonas aeruginosa, which will result to immune response. The chemotactic factors will attract the neutrophils, and the neutrophils will undergo respiratory burst, which will result to cough productive of greenish sputum. The decreased oxygen diffusion to blood and decreased carbon dioxide expiration or decreased ventilation perfusion ratio can lead to hypoxic pulmonary constriction, which will result to increased pulmonary arterioles resistance. then damming of blood in pulmonary arterioles, which will lead to increased capillary hydrostatic pressure, increased fluid filtration to lung interstitium, then increased interstitial fluid pressure. This will result to closing of lymph vessels and decrease interstitial fluid drainage. It will allow the accumulation of fluid in the alveoli, which could be heard as crackles in both lung fields.
Decreased VQ ratio also led to cyanosis.
In another pathway that leads to foul-smelling diarrhea, the more negative intestinal epithelium intracellular space will result to decreased sodium secretion to intestinal lumen. There will be decreased water osmosis to lumen and mucus thickening. There will be increased byproducts of bacterial metabolism such as hydrogen sulfide, which will result to foul-smelling diarrhea. Because of the defect in the pancreas, there is decreased activity of pancreatic enzymes. This will lead to decreased absorption of nutrients and retention of nutrients in the intestinal lumen, which will result to increased fecal fat and foul-smelling diarrhea. In cystic fibrosis, there is a defect in the pancreas. There is a decreased chloride transport to pancreatic acinar duct. There will be decreased exchange of bicarbonate with chloride. The decreased bicarbonate in pancreatic acinar duct will result to increased pH of chyme. There will be inactive pancreatic enzymes or decreased pancreatic enzymes activity, which will result to decreased digestion of nutrients. This will lead to decreased absorption of nutrients, then decreased vitamin K absorption, decreased vitamin K dependent clotting factors, and decreased coagulation. There will be bleeding, which will result to ecchymosis. The increased airway resistance in cystic fibrosis will result to decreased alveolar filling. This will lead to patchy atelectasis.
On her 10th admission, Ariana was already 11 years old. She was brought back to the hospital with a chief complaint of losing 6 kilograms over a period of 3 months. Her recurrent symptoms were suffering from excessive coughing and shortness of breath. Additional symptoms have also occurred, such as complaining of excessive thirst and frequent urination. Her desire to urinate was very severe that Ariane had to wake up several times during the night to do so. Upon physical examination, it showed that she has a thinly built dyspneic, mildly cyanosed, and barrel-chested. Laboratory findings revealed that she has elevated fasting blood sugar, elevated postprandial blood sugar, elevated glycosylated hemoglobin, and glycosuria on urinalysis. In order to treat her symptoms, insulin injection was started, along with advising her parents to limit the sugar intake of Ariana. In the succeeding 5 years, the patient remained dyspneic on exertion with cyanosis. At age 16, she started undergoing nocturnal low-dose oxygen therapy.
At the age of 17, she underwent cardiac catheterization, which shown that her pulmonary arterial pressure was 38 over 22 millimeters mercury, and her pulmonary arterial mean pressure was 28 millimeters mercury. There was no evidence of valvular disease or a septal defect. At the age of 18, physical examination showed her heart rate was 120, and her respiratory rate was 30 at rest and rose to 40 on slight exertion. There were crackles present at both lung fields. An S2 split on inspiration was detected, and her pulmonic closure equaled her aortic closure. There was no murmur or S3 heard. There was also a digital clubbing. An electrocardiogram showed sinus tachycardia at a rate of 123 beats per minute with normal intervals, and the R wave axis was plus 125 degrees with evidence of right atrial enlargement and right ventricular hypertrophy. Pulmonary function remained poor, and arterial blood gas showed that the partial pressure of oxygen in her arteries is 62 millimeters mercury, while that of carbon dioxide was 59 millimeters mercury. Also, bicarbonate levels was 31 milliequivalents per liter, and her blood pH was 7.26.
The increased ketone bodies also increases hydrogen ion. Hydrogen ion is an antiport of potassium ion, meaning as hydrogen ion goes to the intracellular fluid, potassium moves to the extracellular fluid. Due to this mechanism, potassium levels in the serum increases. The increase in hydrogen ion also causes the depletion of bicarbonate and buffering of acid compounds. Decreased bicarbonate levels results in decreased pH.
First, fibrotic changes in the lungs will lead to cystic bronchiectasis, which is the condition wherein the airway is widened and excess mucus builds up in the airway, causing infection and increased airway resistance due to the mucus buildup. Second, fibrotic changes causes a decrease in the lungs compliance, leading to a less negative intra-alveolar pressure and decrease in oxygen volume inhalation, which would appear as a decreased VQ ratio and leads to a decrease in oxygen saturation during exertion and delayed return of normal oxygen saturation at rest. Third, fibrotic changes decrease the elasticity of the lungs. Decreasing the elasticity of the lungs would decrease the carbon dioxide expelled in the lungs, leading to a buildup of carbon dioxide. This stimulates the chemoreceptors to increase respiratory rate, which appear as an increase in FVC during exertion. Lastly, fibrotic changes would lead to digital clubbing. Normally, megakaryocytes would be trapped in the pulmonary capillary bed and are broken down into platelets before entering the systemic circulation. In this case, however, megakaryocytes bypass this process and enter the circulation as such. And as they're trapped in the capillary beds of the extremities, these cells would release platelet-derived growth factor, which would cause enlargement of the distal phalanges or digital clubbing. Another thing to note is that a decrease in VQ ratio would lead to hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction increases the resistance in the pulmonary arterioles, which would increase pulmonary arterial pressure. Prolonged increase of this pressure would lead to pulmonary artery dilatation and volume loss.
At 6 months of age, there were low levels of serum potassium and sodium. To increase these electrolytes, sodium chloride and potassium chloride supplementations were given. Intravenous fluid therapy was also used to correct her biochemical abnormalities. At 8 years of age, the patient had low blood volume that eventually resulted to low blood pressure. Fluid resuscitation was given to increase her blood volume and decrease her risk for hypovolemic shock. Fluid resuscitation is an intervention of replenishing bodily fluid lost through sweating, bleeding, fluid shifts, or other pathologic processes. Test revealed high sweat chloride level, which was managed by having fluid therapy, taking salt supplementation, and staying away from warm conditions. Over the course of time, she suffered from recurrent infection. The thick mucus in the respiratory tract of the patient eventually resulted to proliferation of bacteria to different tissues. It resulted to otitis media, gastroenteritis, inflammation of tonsils and adenoids, and damage to connective tissues of the lungs. Antibiotics such as cefuroxime were given to treat bacterial infection. The patient was subjected to aggressive pulmonary physical therapy to optimize lung function. Chest physiotherapy is also used. It is a technique used to mobilize or lose secretions in the lungs and respiratory tract. Nocturnal low-dose oxygen therapy was used to manage her hypoxia. She was also given supplemental oxygen for her diminishing lung function. At 21 years of age, lung function was severely damaged. Lung transplantation was performed to restore respiratory function.